Hello, everyone. Can you guys confirm that you can see me clearly, hear me clearly? Hello. Okay, great. Okay, so let me just start by introducing myself. My name is Mosad. I'm one of the tutors here at thematchguy. I passed my step 1 exam. I got a score of 282 on my step 2 exam. I'm happy I'm with you guys today. Today we'll be covering high-yield endocrinology topics that are a must know before your exam. But before we jump in, I'd like to ask you, if you haven't already, make sure to check out our high-yield PDF files. They are completely free. You can find them on our website. We'll be sharing the link here in the chat. And for you who are watching later, you can find them in the description. And if you would like more personalized one-on-one tutoring, we also offer that. And one thing that I think we offer is we give you like 30 minutes free demo session with your tutor, so you can just like choose and decide if this tutor fits your learning style. If you like the crash courses, if you like courses styles, we also offer our crash courses, our 7-day crash courses. They are present for both. We have for both step 1, step 2, and step 3. We have 7-day crash course where we cover almost 70 to 80% of all the high yield concepts before your exam. So I'm seeing a message in the chat. Is this for step 1 or step 2? Currently, this session is mostly for step 2 and step 3, but it's going to have also like a lot of beneficial information that also show up in your step 1 exam. So without further ado, let me start. I'm going to share my screen and let's start. So first of all, let me just try to give you a bit of an introduction about how this session is going to go and how it's going to be structured. So first of all, I'm going to start by I'm going to focus on the high-yield adrenal gland disorders, including the congenital adrenal hyperplasias. I know a lot of you guys may have problems with that, the congenital adrenal hyperplasias, the enzymes, what to memorize and what not to memorize. So it's important for us to target the high-yield stuff. And we'll also try to go over some of the high-yield calcium disorders, parathyroid hormone disorders, and vitamin D disorders. How we're going to go over them, we're going to go over them through a series of short STEM questions and in a question and answer format. Why is that? Because I don't want to just give you guys like a lot of information that's there everywhere. I want to give you guys the information and how you can apply them on your exam. How can you apply them to choose the correct answer on the exam? So without further ado, let's jump in. I want you guys to try to be as interactive as possible with me. Try to share your answers. Okay. Okay, let's start. So let's start with this question where we have a 62-year-old chronic smoker with fatigue, weight loss, hyperpigmentation, proximal muscle weakness, hypokalemia, and hyperglycemia. What do you guys think the most likely diagnosis is? I want you guys to try to share like what you have in mind with me. Okay, Tanya is saying A. Okay, I'm seeing a lot of A's. Okay, so I'm seeing a lot of A's. Okay, the answer is actually B. And let's go over why the answer is B and why it's not A, because the majority chose A. First of all, how are we going to approach this question? It's paraneoplastic Cushing syndrome. What is Cushing syndrome? Cushing syndrome is basically a pathological increase in cortisol. So what does cortisol do? And when it increases pathologically, what's going to happen? First thing, why do we have a proximal muscle weakness? Cortisol is a catabolic hormone. It's going to destroy proteins, right? So you're going to have muscle weakness, myopathies. Myopathies mainly present in the form of proximal muscle weakness. You're also going to have hyperglycemia because there is some sort of insulin resistance because cortisol is an anti-insulin hormone. So you have insulin resistance causing hyperglycemia. You can also see hypertension. Hypokalemia. Why is there hypokalemia? Because cortisol has a mineralocorticoid receptor-like action. What what do mineralocorticoids do? They increase the what do they do? They increase the reabsorption of sodium, and then water accompanies sodium, and hence you have the hypertension, and they increase the excretion of potassium and hydrogen ions. So you're going to have hypokalemia, and you can also have some metabolic alkalosis. Believe me, guys, these electrolyte disturbance can, in a lot of cases, hint you back to thinking about Cushing syndrome. Okay, usually we're going to have abnormal fat distribution, maybe weight gain. So why is there weight loss here? That seems odd. And that's why our answer is actually paraneoplastic Cushing syndrome. That's one of the high-yield clues and keywords for us to think about, paraneoplastic Cushing syndrome. Before getting into paraneoplastic Cushing syndrome and specifically, I want to know, first of all, how we go step by step in diagnosing, first of all, Cushing syndrome, and then our specific diagnosis here. Because one thing about endocrinology is you have to follow order. You have to go in order of investigations. You cannot jump a step, okay? And believe me, this is an important cause of mistakes in questions. So the first thing is I want you guys to confirm Cushing, okay? Confirm Cushing. So, okay, I want you guys to confirm Cushing. How are you going to confirm Cushing? First of all, you are going to do a 24-hour urinary cortisol test. Okay, so if they ask you what the next step is, I don't want you guys to go jumping into chest X-ray, or even though you know it's a paraneoplastic syndrome mostly caused by a lung cancer. No, it's a trick. The first step is confirming the diagnosis by, for example, a 24-hour urinary cortisol, a late night salivary cortisol test, and or a low dose dexamethasone suppression test. Okay, so any of these is sufficient to confirm the diagnosis of Cushing syndrome. We have increased cortisol. Then the next step, and that's very important, is differentiating. We have to classify it into either ACTH dependent hypercortisolism or Cushing, or ACTH independent. Independent meaning the adrenal gland is functioning autonomously. There is a tumor, the most common cause, a tumor causing increased cortisol, and as a result of negative feedback, it's decreasing ACTH. So what's the next step? So now the first step is confirm. The second step is look for ACTH. The next step is if you have the low ACTH, we know it's an adrenal gland tumor. Maybe, mostly it's an adrenal gland tumor. So we're going to do some sort of abdominal imaging, okay? Abdominal imaging, maybe CT abdomen or MRI abdomen. Okay, so we're going to do some sort of abdominal imaging. What about if there is increased ACTH? Here I have two possibilities. The first possibility is our diagnosis over here, paraneoplastic syndrome. And what's the most common tumor that causes this paraneoplastic syndrome of increased ACTH? It's small cell lung cancer of the lung. Okay, so small cell lung cancer. The other possibility is it's just a pituitary tumor, right? That's, yeah, a pituitary tumor secreting increased ACTH and then causing increased cortisol. How are you going to differentiate between them? We usually differentiate by either a high dose dexamethasone suppression test. And what will high-dose dexamethasone suppression test, how is it going to affect either the pituitary tumor or the paraneoplastic syndrome? How is it going to make us differentiate? So first of all, high-dose dexa. It's a cortisol. It's one of the derivatives. It's a glucocorticoid, right? So it's going to suppress the normal axis. So it's going to suppress pituitary ACTH that is secreted by the pituitary, because that's the normal axis, right? But a paraneoplastic syndrome, that's abnormal. That's a tumor, right? So it will not have any effect on this. Okay, so it's going to suppress pituitary secretion of ACTH, but it's not going to suppress lung cancer secretion. Okay, this seems hard. This seems complicated. In questions, how do I actually want you to differentiate between them? It's actually by the clinical picture. So from the clinical picture, if you have a chronic smoker, and here, this is the reason for the weight loss, because it's cancer, I want you to think paraneoplastic Cushing syndrome. In questions, typically, if they give you lung symptoms, for example, cough, for example, hemoptysis, in an old patient, mostly with the Cushing syndrome, mostly they want you to think about lung cancer. The second thing, hyperpigmentation. Hyperpigmentation here hints to increased ACTH. So the increased ACTH is also associated with increased something called melanocyte stimulating hormone, increased MSH. So hyperpigmentation, just one word, is already hinting me towards increased ACTH and making me think about this particular category. Why isn't it Addison's disease? Addison's disease is the opposite. It's coming up in a later slide, but Addison's disease is decreased cortisol. Here you're going to have hyperkalemia. You're going to have hypoglycemia, not hyperglycemia, okay? Along with other features. Okay, so basically, these are the manifestations. We explained why they happen. Another important manifestation is the psychiatric symptoms, particularly anxiety, insomnia, or depression. Cortisol can present with such psychiatric manifestations as well. Okay. Okay, Addison, we're going to discuss Addison in an upcoming slide. Okay, so let's go over this question. A 31-year-old woman with weight gain despite diet, proximal muscle weakness, hirsutism, menstrual irregularity, hypertension, and hyperglycemia. What is the best next step? What do you guys think? Okay, perfect. Now you're getting the idea. Now you're getting the idea. If they say the next step, and believe me, guys, this is also another source of error in a lot of questions. People do not read the question well. Are they asking the best next step? Are they asking a definitive step? Are they asking about a specific thing? You always have to read the question really well. So what is the next step? Yeah, we said we're thinking mostly here about Cushing syndrome. We said the first thing we want to confirm Cushing. We're going to confirm by one of the three tests we just mentioned, which is 24-hour urinary cortisol. Why are we thinking about Cushing in the first place? Again, we said weight gain despite diet. Here it's a classic finding. We have the proximal muscle weakness. We have the hirsutism, menstrual irregularities. So with Cushing syndrome, there is also a slight abnormal increase of androgens, and hence some of these manifestations of hyperandrogenism. Okay, we have the hypertension and the hyperglycemia. A lot of people actually choose C, measure testosterone levels. Why? They think about PCOS. And it kind of makes sense. We have signs of hyperandrogenism. We have menstrual irregularities. Why isn't not PCOS? Because I have other features. Guys, read all the keywords in the question. I have the proximal muscle weakness. I have the hypertension. I have the hyperglycemia. These are not explained by PCOS. Okay, perfect. Okay. Why hypertension? Because cortisol has a mineralocorticoid receptor-like action. It increases the absorption of sodium. Water accompanies sodium, and so you have volume expansion, you have expansion, and so you have hypertension. The other reason is, as Dr. Dre mentions in the comments, is cortisol also increases the vascular tone. Okay, perfect. So this question, we have a patient on chronic corticosteroids undergoing emergency appendectomy. Post-op, he becomes confused, hypertensive, and fluids fail to raise his blood pressure. What is the diagnosis? Okay, a lot of you guys already answered it. Perfect. It is C. Why C? Acute adrenal insufficiency. This is one of the most important and one of the most high-yield questions that are most common in any exam. So why C? Why acute adrenal insufficiency? So what's happening here? Here, yeah, I know we made it clear by saying a patient with chronic corticosteroids. Usually in a big question stem, you have to be searching for this keyword. Okay, you have to be searching for the steroids. They're just going to start a question vaguely, maybe even talk about the pain from appendicitis or whatever, and then tell you that they reached the diagnosis, and then tell you that they did an appendectomy, and then post-op he becomes confused, hypertensive, and fluids fail to raise his blood pressure. Till now, they haven't even mentioned the corticosteroid ports. But if you know about this scenario, if you have it in mind, particularly the fluids failing to raise his blood pressure, you're going to go to the past history, you're going to go to the medical history and look at his medications, look at the history. Mostly this patient is going to be a lupus patient, rheumatoid arthritis patient, sarcoidosis, whatever, and he is on chronic steroids. And one thing about being on chronic steroids is this suppresses the normal hypothalamo-pituitary axis. And so the adrenal glands are no longer secreting cortisol. It's just now the steroids that we're giving from outside. So in such stress conditions, a normal person compensates by increasing ACTH and increasing cortisol to try to adapt to this stressful condition. But this person's HPA his hypothalamic pituitary axis is suppressed. So we have, as doctors, to anticipate for this and increase his steroid dose. Here, they didn't increase his steroid dose. That's why he got into this acute adrenal insufficiency attack. So how are you going to treat it? Here, it is a must for you to give IV hydrocortisone, okay, plus or minus something called fludrocortisone. So fludrocortisone is a mineralocorticoid receptor agonist, and it's also going to help with the hypotension. And here, and this is a must give, and this is the treatment. Okay. The second thing that you guys need to know is if we're stopping steroids, the same concept, if we're going to stop this drug. So we have to do something called gradual tapering. Okay. Like decrease the dose bit by bit to give time for the adrenal gland to come back and the hypothalamic pituitary axis to start functioning again. Okay. So that's our diagnosis over here. And another high yield cause of this acute adrenal insufficiency is this one, the meningococcemia. What happens in meningococcemia? Do you guys remember the fancy name? The Waterhouse-Friderichsen syndrome. In meningococcemia, you could get adrenal gland hemorrhage. So the adrenal gland all of a sudden stops functioning. All of a sudden, no cortisol, acute adrenal insufficiency. What is the treatment? The same treatment, IV hydrocortisone plus or minus fludrocortisone. Okay, perfect. Let's discuss this question. A 29-year-old woman with a history of hypothyroidism complains of fatigue, weight loss, nausea, abdominal pain, generalized weakness, and orthostatic hypotension. The labs show normal CBC with eosinophilia. What is the most likely diagnosis? Okay. Okay, what is the likely diagnosis, guys? Yes, Tanya, that's different from Shihan. Okay, here I'm still seeing mixed answers. So that's the diagnosis we've been waiting for. That's the adrenal insufficiency diagnosis. Okay, so it's either B or C. What makes us choose B over C or C over B? First of all, yeah, the answer is actually B. It's primary adrenal insufficiency. Let's discuss this part of the answer, adrenal insufficiency. Why is it adrenal insufficiency? First of all, yeah, we have decreased cortisol, right? If we have decreased cortisol, this is going to explain some of these findings of the fatigue, the weight loss, the weakness, the orthostatic hypotension, because we said cortisol has a mineralocorticoid receptor-like action. So with decreased cortisol, you're going to have decreased sodium and water. So you have the hypotension, opposite to Cushing syndrome. You're also going to have hypoglycemia. And you're going to have hyperkalemia. And maybe metabolic alkalosis. Sorry, metabolic acidosis. Here we're no longer losing potassium and hydrogen ion in the urine, so you can have hyperkalemia and metabolic acidosis. Okay, why the nausea and abdominal pain? Unfortunately, we do not know. No one knows, but it is a classic finding. So it is classically associated with adrenal insufficiency, abdominal pain. That's an important finding as well. Okay, and then we have this weird, like random finding of eosinophilia. Actually, this is what usually hints me towards this diagnosis. If I haven't thought about it while I'm reading the question, and then I go to the labs and see eosinophilia, I go back and read the question, and now it comes to me, adrenal insufficiency. So decreased cortisol is just associated with, and like there is increased demarginalization of eosinophils. So instead of sticking on blood vessel walls, they just demarginalize, i.e. like fall from the blood vessel wall and increase in the blood. So we have eosinophilia. Okay, it's just a finding that's very characteristic for adrenal insufficiency. Okay, now we have our answer why it's adrenal insufficiency. Then why is it primary and not secondary? How to differentiate between primary and secondary? First of all, what does primary adrenal insufficiency mean? It basically means that the whole adrenal gland is blown out. Okay, and the adrenal gland has what cell lines, or what does it release? It's not just cortisol. We also have aldosterone, right? Aldosterone is also decreased. Aldosterone is not going to be released here. So the clinical picture of a primary adrenal insufficiency is going to be much more severe, because the aldosterone here being not there, okay, being decreased, is the main reason why there is the orthostatic hypotension, the fatigue, the hypoglycemia, okay? But in secondary adrenal insufficiency, it's secondary, okay? We only have decreased ACTH from the pituitary. The ACTH only affects, so it's the hypothalamic pituitary axis, only affects cortisol. It's going to cause decreased cortisol, but there is not going to be decreased aldosterone. Okay, so secondary is going to be much less severe. Okay, so that's the first finding. The second thing, it's not mentioned here in the question, but let's go over it. If we have destruction of the adrenal glands, we have low aldosterone, let's say low cortisol. As a result of this, as a result of positive feedback, we're going to have increased ACTH. And we said increased ACTH is associated with, can clinically present by what? Hyperpigmentation. If I have hyperpigmentation in the question, this easily makes me think about primary adrenal insufficiency. And the third reason is, and that's very important not only for this question, but for any autoimmune condition. They said history of hypoparathyroidism for a reason. Now we'll start, after we're done with this part, we'll start solving actual questions for from our Synapse QBank. And I'll show you how, like, focusing on these keywords is what's going to get you the answer. So history of hypothyroidism tells me what? Hypothyroidism was the most common cause of hypothyroidism. It's Hashimoto's thyroiditis. Hashimoto thyroiditis is autoimmune. So if they tell me this, if they tell me vitiligo, if they tell me diabetes, type 1 diabetes, if they tell me what else, primary biliary cirrhosis, any autoimmune condition, I'm mostly thinking autoimmune conditions like to come with each other. So I'm thinking of primary adrenal insufficiency. Because what are the causes of adrenal insufficiency? The most common cause is autoimmune adrenalitis. And that's the one that we actually call Addison's disease. Okay? Okay. So that's why it's going to be primary in this question and not secondary. Other important causes of primary adrenal insufficiency is TB, adrenalitis. So TB, so the keywords in the question, again, it's all about keywords, is they are going to tell me like the patient is an immigrant, or they are going to give me some lung/chest symptoms. Okay, and the third common cause that's also important to know for your boards is the metastases, and it's important to know that these like malignancies like to metastasize to the adrenal. So you have the breast, you have the lungs, and you have, and that's very, very high yield melanoma. Okay, I hope this clears it up. Okay, perfect. Okay. So let's approach this next question. We have a 32-year-old woman that presents with 3 months of mild headaches and generalized weakness. Vitals are blood pressure of 150/105, heart rate of 80, and the labs show hypokalemia and metabolic alkalosis. What is the diagnosis? Okay, great, great. So I'm seeing A in the answers. Okay, everyone is saying A. But there is a misconception about this question. So hyperaldosteronism does not always mean Conn's syndrome. Okay, let me explain. So yeah, there is hyperaldosteronism here in this case. What makes me think about hyperaldosteronism? I have a lot of aldosterone. We said aldosterone is going to cause sodium reabsorption. Water is going to accompany it. Volume expansion, hypertension. One of the very important high-yield causes of secondary hypertension. The second thing we said, aldosterone, high aldosterone dumps potassium and dumps hydrogen ion in the urine. So we have hypokalemia and metabolic alkalosis. Classically, on questions, hypokalemia causes generalized weakness. That's how it clinically manifests. And that's the reason for the generalized weakness in this question. So for these secondary hypertension questions, guys, it's very, very high yield. It's very high yield. How to differentiate between all of them? Every single cause has its own keywords. So how to get hyperaldosteronism as the cause? Basically, you're going to jump to the lab abnormalities. So if they tell you a case of secondary hyperaldosteronism, secondary hypertension, and they tell you electrolytes are normal, like the routine labs are normal, then that's not hyperaldosteronism. Okay, so we have our diagnosed hyperaldosteronism. Is this enough? No. The next step, and they usually ask you what is the next step. The next step is actually measuring something called plasma aldosterone to renin ratio. Again, like I told you guys in the beginning, endocrine is all about step-by-step diagnosis, step-by-step. Okay, so plasma to aldosterone renin ratio. We're either going to have an increased plasma aldosterone to renin ratio, more than 20, and this indicates what? This indicates that there is a primary disorder within the adrenal gland, like the most famous cause that we always talk about, which is an adrenal tumor. Okay, adrenal tumor, and here we are going to call it Conn's syndrome. Okay, so you have an adrenal tumor. Or the second important cause as well is bilateral adrenal hyperplasia. And that's what's causing the increased aldosterone release. Okay. Okay. So how am I going to differentiate between them? The next step is actually going to be some sort of imaging of the abdomen. Again, either CT or MRI. Why? A tumor is going to appear on imaging, right? So if I see a tumor, that's it. But if there is no tumor, I'm mostly thinking this is bilateral adrenal hyperplasia. Okay? So why is this important? Because management depends on us getting the cause. A tumor, how are you going to treat it? It's easy. Just do surgery. Just remove it, right? It's a tumor. What about bilateral adrenal hyperplasia? Can you just remove both adrenal glands? It doesn't make sense, right? So how are you going to treat it? Here, we're going to give drugs. What kind of drugs are we going to give? Aldosterone antagonists. Yes, like spironolactone and eplerenone. Okay, these are mineralocorticoid receptor antagonists. Okay. The second possibility, decrease plasma aldosterone to renin ratio of less than 20. This means that here, the primary event that happened is we have increased renin. And you guys know the cascade, the famous increased RAS system, renin, angiotensin, aldosterone system. So if there is something primarily increasing the renin, and that's causing secondary increase in aldosterone. So what are we thinking of here mostly? I'm thinking one of the very most high-yield causes in USMLE is renal artery stenosis. The kidney senses decreased hypoperfusion, as if there is decreased blood pressure. It's going to compensate by increasing renin, so increasing aldosterone and angiotensin and aldosterone. Okay, the second cause is very low yield, but just for the sake of mentioning it, a renin secreting tumor. Okay, so that's how you approach hyperaldosteronism in some cases, and step by step, you have to know what step you're in order to choose the correct answer. It's easy. It's just knowing these steps. Okay. Okay, perfect. Okay, so this is basically what we just said. So this is how aldosterone works. It increases sodium reabsorption, potassium and hydrogen excretion, and hence you have the hypertension, the hypokalemia, the metabolic alkalosis, and the famous aldosterone escape theory. So what happens is this hypertension or increased blood volume causes stretch of the blood vessels, and it also causes stretch of the atrium and of the ventricles. So you're going to have increased atrial natriuretic peptide. And what does this do? This just causes pressure natriuresis. It just causes increased sodium excretion and taking water with it. So it limits further sodium retention. It causes a balance. Yeah, we're on the hypertensive side, but not to the degree of causing severe edema. Okay, that's basically the explanation behind the aldosterone escape mechanism. Okay, now this is a very, very high yield question, guys. Okay, I want you to focus me with this question. So we have a 10-year-old girl that presents with 6 months of hirsutism, acne, and clitoromegaly. She has normal testosterone, increased DHEAS, increased 17 keto steroids, and a normal pelvic ultrasound. What is the diagnosis? Okay, I'm seeing D in the answer choices. Okay, any other answers? Okay. Perfect, perfect. You guys got it. So it is the adrenal adenoma secreting androgen. So again, like we always do, we're first going to explain the first part of the answer. Why is it an adenoma secreting androgen? And then why is it adrenal and not ovarian? One term, very important, I want you to be familiar with it is virilization. What is virilization? Virilization just means severe hyperandrogenism. Okay. By virilization, I mean clitoromegaly, which we have here in this question, increased muscle bulk, and deepening of voice. Okay. What about the acne and the hirsutism? These are just manifestations of hyperandrogenism. So if I just have acne, hirsutism, I'm mostly thinking of something more mild like Cushing syndrome, PCOS, some benign, some mild increase of androgens. But clitoromegaly, I'm thinking virilization. Virilization in my mind equals, no, I want to have a tumor, adenoma. Okay, that's virilization. So that's why the adenoma secreting androgen. Okay, why adrenal and not ovarian? First of all, this is very important, this marker. The increased dehydroepiandrosterone sulfate, the S, always equals adrenal cause. If this is not increased, then it's ovarian cause. The second part, which of course makes it easy, the normal pelvic ultrasound, and ovarian adenoma in general is going to appear on a pelvic ultrasound. Okay, so that's how you approach it step by step. Okay, PCOS, because it's one of the most important causes of hyperandrogenism, how we usually diagnose it, we need to have 2 out of 3 criteria. So we need to first have hyperandrogenism, okay, either clinically or on labs. So the presence of hirsutism and acne on own can be sufficient for us to diagnose hyperandrogenism, okay? And the second criteria is going to be some sort of menstrual irregularity, usually amenorrhea or oligomenorrhea. And the third criteria is seeing cysts on ultrasound, okay? So cysts on ultrasound. Okay, let's go over the next question. And we're also going to go back to the previous question after we finish this question to try to contrast between both of them. So we have a 10-day-old girl that presents with poor feeding, vomiting, lethargy, dehydration, hypotension, and hyperpigmentation. She has ambiguous genitalia. What is the diagnosis? What do you guys think? Okay, perfect. B, it's classic congenital renal hyperplasia. Okay, so let's go over why it's classic congenital adrenal hyperplasia and the diagram that's usually a nightmare for a lot of people, but we'll try to simplify it as much as we can. First of all, these are the enzymes that can be affected in congenital adrenal hyperplasia. We'll go over them one by one, and then I'll tell you if you just want the high yield, the most important things, what to remember. If you want to choose one number, I'll tell you what to remember, and I'll give you a mnemonic at the end. So first of all, we're going to start with this enzyme, 21 alpha hydroxylase deficiency. So if it is deficient, I'm going to draw a line here. So anything down here is going to be decreased. So what am I going to have? I'm going to have decreased cortisol, right? And its manifestations of like fatigue and so on. And I'm going to have decreased aldosterone and hence the salt wasting syndrome. That's what you saw in the previous question. You have hypotension and salt wasting syndrome. And then all the metabolites are going to be shifted down this road. And so you're going to have increased androgens. Okay, hence the ambiguous genitalia in a genotypically female infant. Okay, 21 alpha hydroxylase deficiency, that's responsible for 90% of cases. If you want to remember one of them, remember 21 alpha hydroxylase. Okay, if 21 alpha hydroxylase is deficient, so again, we drew a line here, what's going to be increased? This metabolite. Very high yield. I cannot emphasize how high yield this is. You are going to have increased 17-hydroxyprogesterone, and that's why this is going to be used as a marker for 21 alpha hydroxylase deficiency. Okay, if we have 11 beta hydroxylase deficiency, we're drawing a line here. We're also going to have decreased cortisol. We're going to have decreased aldosterone, but watch out. We're going to have increased this like metabolite, which is 11 deoxycorticosterone. And this has weak mineralocorticoid-like action. And so it's going to actually cause hypertension. So we don't have hypertension. No, we have hypertension because of this metabolite. And then we're also going to have the same increased androgens. Again, we're shifting the pathway over this direction. And the last enzyme deficiency is the 17 alpha hydroxylase deficiency over here. Here it's the opposite. Here we're blocking this pathway and we're also blocking this pathway. So decreased cortisol is common, all of them. We're blocking this pathway, so we're having decreased androgens. And this pathway is free to function. So we have increased aldosterone. And you have increased aldosterone, you're also going to have the hypertension. Okay, this is very confusing. I cannot memorize it. Okay, let's check this mnemonic out. So 21, if it ends in 1, you are going to have what? Increased androgen. 17, okay, if it starts in 1, you are going to have hypertension. And 11, if both, of course, so you're going to have increased androgen and hypertension. Test this mnemonic out, and I'm sure it's going to work. But again, if you want to remember one thing, remember the 21 alpha hydroxylase deficiency. Okay, going back to our previous question, I think it now makes sense. We have the poor feeding, the vomiting, the lethargy, the dehydration because of the decreased cortisol and aldosterone, and the hypertension. We have ACTH because in response to the decreased cortisol, we have increased compensatory increase in ACTH, causing this hyperpigmentation. Okay, going back to our Okay, let's go to the next question first and then go back to the previous question. Okay, this is a related question. A 32-year-old woman with hirsutism and irregular menses, she was found to have elevated 17 alpha hydroxyprogesterone. After 6 months of prednisolone, her menses normalized and her hirsutism improved. Repeat 17 hydroxyprogesterone dropped. What is the diagnosis? So the difference between this condition and the previous one is just one word. Yes, yes, you guys are getting it. Okay, so it is the non-classic congenital adrenal hyperplasia. What is the difference? So in non-classic congenital adrenal hyperplasia, you just have partial deficiency of the 21 alpha hydroxylase enzyme. So if you have just partial deficiency, it's not going to be this severe. So it's not going to, first of all, it's not going to manifest in a newborn. So as you can see here, that's an adult. Mostly the most common time for it to present is around. Okay, what is the only presentation? Just manifestation of increased androgen. Again, it's mild, so just decreased androgen causing just some of the hyperandrogenism manifestations that we said, like something like hirsutism, acne, irregular menses because of affection of the the HPA axis and so on. So you just have some increased androgen. Something else that is very important that they ask in all steps is the mode of inheritance. What's the most likely mode of inheritance? So 21 alpha hydroxylase deficiency is autosomal recessive. Okay, let's go back to the first question, where a lot of people get confused here and say, why is this not congenital adrenal hyperplasia? So yeah, increase the HEAS, that's an adrenal, okay? We just said this says adrenal, whether it's adenoma, whether it's congenital adrenal hyperplasia. But what age is this patient? It's 10-year-old. So if she is going to have congenital adrenal hyperplasia, it's going to be what type? The partial type, the non-classic type. And the non-classic type, we said what? It's mild hyperandrogenism, just hirsutism and acne. And back to our first point, that's why I emphasized that the virilization part. So once you see virilization, I'm not thinking of anything mild. No, I'm thinking of a tumor. So again, highlighting this very important point. Okay, moving on to our next question. So moving on to some other parts of the adrenal glands, a 42-year-old woman with episodic headache, sweating, palpitations, and resistant hypertension, and adrenal mass on MRI consistent with pheochromocytoma. What is the next best step? Okay, perfect. A classic question of administering phenoxybenzamine. So what's happening here? That's pheochromocytoma. What's the key word for it? It's a cause of secondary hypertension and classically causes episodic release of catecholamines, episodic sympathetic stimulation. You have headaches, sweating, palpitations, again, episodic. The next step in pheochromocytoma, as we said, we always go in a hierarchy. In endocrine, we usually want to confirm the hormonal abnormalities first and then move on to the imaging. So the first thing I'm going to do is do either urinary or plasma. Okay, both work, by the way. Metanephrines. What are metanephrines? These are just the metabolites of catecholamines. If they are increased, this confirms my suspicion of pheochromocytoma. Next step is the MRI that they did here to localize an adenoma or a cause. And so, yeah, we have our diagnosis for pheochromocytoma. Okay, why give phenoxybenzamine? Phenoxybenzamine is an irreversible alpha blocker. So I need to give an alpha blocker if I give propranolol first, okay, which is a beta blocker. Now I have increased catecholamines acting only non-opposed alpha stimulation. Non-opposed alpha stimulation, severe malignant hypertension. Okay, that's why I first need to give a phenoxybenzamine, block the alpha receptors for like 3 days or so. And then I'm also going to give propranolol to block beta receptors to decrease the heart rate and protect the heart. Okay, so we first give phenoxybenzamine alpha blocker and then propranolol, a non-selective beta blocker. Okay, let's just get into some high-yield calcium and PTH and vitamin D disorders and move on to doing questions together. So we have a young man who has high calcium, low phosphate, and subperiosteal bone resorption. What do you guys think is the most likely etiology? Okay, perfect. Okay, I'm seeing the correct answer. Everyone is saying A, primary hyperparathyroidism. Okay, So what makes us think about primary hyperparathyroidism? And let's dissect all of these calcium and PTH abnormalities together. Okay, so we no longer get them confused. So first of all, we have, I like in these arrows question, I know these are a nightmare for a lot of people, whatever they are about, like calcium or whatever. Believe me, guys, if you start with the primary event and then start to visualize it, imagine it, you do not need to memorize it. Okay, everything is going to come on its own. So primary hyperparathyroidism, let's just translate it literally. Abnormal increase of PTH. That's the primary event. If I have increased PTH, how does PTH work? It works by to increase calcium and decrease phosphorus. If I have increased calcium and increased phosphorus, that's my diagnosis, which I have here, high calcium and low phosphorus. That's primary hyperparathyroidism. Why the subperiosteal bone resorption? One of the sites of action of PTH is it works on bone, breaks down bone, and so in order for it to increase calcium, so you have this subperiosteal bone resorption, classically called brown tumors. Okay. Let's discuss other abnormalities. For example, let's go on and discuss the secondary hyperparathyroidism. So in secondary, it's a secondary, right? So the primary event that I'm starting with is mostly decreased calcium. And that's the PTH function, is to increase calcium back to normal. So it's going to increase in an attempt for it to increase calcium back to normal so the calcium can actually be normal. So we can have normal or decreased calcium. And if I have increased PTH, how is phosphorus going to be affected? Yes, it's mostly going to be decreased. But here is the caveat. What is the most common cause of secondary hyperparathyroidism? I want you guys to think of. It's usually CKD, chronic kidney disease. In chronic kidney disease, I'm losing. So what is the primary thing that's happening in chronic kidney disease? I actually have phosphorus retention, phosphate retention. That's the primary event. Phosphate retention is going to cause decreased calcium, and so decreased calcium is going to cause increased PTH in an attempt for it to normalize the calcium back again. Okay, so that's number one, number two, number three. Okay, so if I have increased phosphorus, normal to decreased calcium, increased PTH, and they tell me CKD in the questions, that's secondary hyperparathyroidism. Okay, what is the second important cause? So that's our first cause, CKD. The second cause is vitamin D deficiency. So if you have vitamin D deficiency, you are going to have both decreased calcium and decreased phosphorus. So vitamin D deficiency, decreased calcium reabsorption, decreased phosphorus reabsorption. The body is going to try to compensate by increasing PTH reabsorption. Vitamin D deficiency classically on questions, and again, it's a game of keywords, guys. I want you to approach it like a puzzle game words. If they start the question by saying the patient has celiac disease, or the patient has Crohn's disease, or some sort of any fat vitamin malabsorption syndrome, then and they start talking about calcium and calcium stuff, or they start talking about bone pain and muscle weakness, you think vitamin D deficiency even before seeing the labs that they are giving you. Okay, now let's move on to the last cause of hyperparathyroidism, which is actually tertiary hyperparathyroidism. Tertiary. So what happens in tertiary is now it's almost the same picture like primary. So what happens? So mostly it is a complication of CKD. How are you going to identify tertiary on exam? End-stage kidney disease patient who has increased PTH, increased calcium, and decreased phosphorus. So wait a second. This is almost identical. It is identical to the first one that we discussed, primary hyperparathyroidism. So how am I going to diagnose it? By this keyword. If they tell you end-stage kidney disease, that's my keyword. I'm choosing tertiary. So in this kind of questions, I don't want you to think that's the clue. Believe me, tertiary end-stage kidney disease, that's the answer. Okay, I hope this clears it up. And also, always, as I said, always start with the primary event that's happening and just go down the flow and you'll get the answer. Okay, moving on, let's discuss just primarily if we have hypercalcemia, a hypercalcemic question. Mostly, how would hypercalcemia present? Constipation, okay, abdominal pain. A very important manifestation is polyuria. Why? Because hypercalcemia is actually a cause of nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus means kidney, there is resistance of the tubules to ADH, so you're losing a lot of free water, so polyuria, maybe psychiatric manifestations, and so on. Okay, you have hypercalcemia, any hypercalcemia, even if you know the cause, if they tell you the first step, even if it clinically, you kind of know the cause. They tell you the next step, you always choose what? PTH. Why? Because we said we're always going step by step in endocrinology. So the next step is for me to classify it into either increased PTH, which we call PTH dependent, or decreased PTH, which we call it PTH independent. There's something else causing this increased calcium. This increased calcium is then causing, as a result, suppression of PTH. So increased PTH, that's either the usual ones that we discussed, either primary hyperparathyroidism or tertiary hyperparathyroidism. And we discussed that tertiary hyperparathyroidism, I'm going to identify it by being in end-stage kidney disease patient. Okay, decreased PTH, something else causing the increase in calcium. And as a result, the body is going to compensate, trying to get calcium back to normal by decreasing PTH. So the first cause I want you to think of, which is very, very, very high yields, multiple myeloma. Multiple myeloma, if you see a patient with hypercalcemia, anemia of chronic disease, and bone pain, especially back pain, especially an older patient, and maybe AKI or some sort of kidney dysfunction, you think of multiple myeloma. The second cause, so here we have a couple of causes that fall under the category of malignancy. So the second cause that's very, very, very important is squamous cell carcinoma of the lung. Squamous cell carcinoma of the lung. Why? Here it's a different mechanism. It increases, it's a paraneoplastic syndrome where there is increase in PTH-related peptide. So PTH-related peptide, that's a different molecule, but acts on PTH receptors. So increasing calcium, but here, again, what's important is you have decreased PTH. Okay. By the way, renal cell carcinoma can also present by this paraneoplastic syndrome, so keep this in mind. Okay, something else, just the usual metastases that you can have. Mets, okay, causing bone destruction, hypercalcemia, and so decreased PTH. Lymphoma, okay? Lymphoma causing increased PTH. How? Different mechanism. Abnormal vitamin D activation. So if you have abnormal vitamin D activation, you're going to have increased calcium levels. So these all fall under the umbrella of malignancy. Usually in a question, if they want to tell you about malignancy, they are going to give you a slightly bit increased calcium, like more than 12. The usual range is between 8.5 to 10. Okay, mostly they are going to 10.2. Mostly they are going to make it more than 12 to make you think about malignancy. Other important causes, and here we're again back to playing the game of keywords. For example, we have sarcoidosis. Sarcoidosis on a question, African American women, bilateral hyaline-lymphadenopathy, lung symptoms, cough, or cough and shortness of breath. You're thinking of sarcoidosis. Next step, do chest X-ray, treatment, give steroids. What other important causes do we have? We have vitamin D intoxication. And this is easily identifiable from the question. Okay, so these are the highest yield causes of hypercalcemia. Again, step by step, if you have decreased PTH, I'm already thinking down this road, I'm not thinking down this road, and every one of them has its own keyword. Let's apply our knowledge in the upcoming couple questions. So if we have a patient with chronic kidney disease that has bone pain and elevated alkaline phosphatase, what condition best explains these findings? What do you think? Okay, I'm seeing a lot of these, okay? And the question, and I'll tell you the source of confusion here. Paget disease, we usually link it to elevated alkaline phosphatase. And once you guys saw the elevated alkaline phosphatase, then it's Paget disease. Let me just like indicate that this is the wrong answer. It's actually secondary hyperpar. So remember, guys, the game of keywords that I told you about? If they're telling me chronic kidney disease, and they are emphasizing it, that's the only thing they mentioned here in the question other than the bone pain and the elevated alkaline phosphatase. They mostly want me to think about something related to it. CKD is going to cause what? Secondary hyperparathyroidism, like we mentioned, phosphorus retention, decreased calcium, and increased PTH in response. Elevated alkaline phosphatase is just a non-specific marker that just says there is increased bone remodeling. Okay, Paget disease, if they wanted to present in an exam, first of all, they are not going to emphasize on the CKD. Second of all, you're going to have the classic cranial nerve findings like hearing loss, Okay, they are going to tell you maybe, yeah, as I said, it's not going to be a CKD patient, and the only abnormality that you're going to see is increased ALP. So everything else in Paget disease patient is going to be normal, calcium is going to be normal, PTH is going to be normal, everything is going to be normal. So again, we're getting this answer correctly by the what increased ALP is related to the scenario. Okay, so as I mentioned, guys, so the elevated ALP is just a non-specific biomarker of bone remodeling. Okay, so you're going to have it with vitamin D deficiency, Paget disease, hyperparathyroidism, whatever. Okay, so it's secondary hyperparathyroidism. Okay, so CKD, as we said, leads to phosphate retention and low calcium in addition to decreased vitamin D activation. So that's something else. Where does vitamin D get activated? Vitamin D gets activated in two sites. First of all, the liver, and clinically and in questions, we don't care about that. And the second site of activation by 1-alpha hydroxylase enzyme is in the kidneys. So it's by 1-alpha hydroxylase enzyme. And what actually stimulates this enzyme in the kidneys, it's vitamin D. So, sorry, it's PTH. Okay, so PTH, one of its actions on the kidney is it activates 1-alpha hydroxylase, so we get active vitamin D. And that's also another reason why in CKD you have decreased calcium level, and so causing the high PTH and the cascade we discussed. Okay. An elderly smoker has hypercalcemia with suppressed PTH. What is the most likely etiology? The game of keywords, guys, before you answer. So hypercalcemia, down the road, we went to this site, suppressed PTH, so we're in this site that's PTH dependent. Elderly smoker, they must be telling me about a lung cancer. That's their way of saying lung cancer in a question. So we have lung squamous cell carcinoma secreting PTH-related peptide. Okay, so you guys, how you think about it, how you look for keywords, and how you flow down step by step. Okay. An African-American patient presents with dry cough, hypercalcemia, suppressed PTH. What is the most likely explanation for this presentation? We already said game of keywords, sarcoidosis, African-American women. They started to tell me dry cough, mostly because of the interstitial lung disease, hypercalcemia, suppressed PTH. So again, we're in the PTH independent side. We're not thinking, for example, about primary hyperparathyroidism. And so we have sarcoidosis. We do chest X-ray, treatment, steroids. And guys, just a tip for you guys, never choose ACE levels as your way of diagnosing sarcoidosis. It is classically, okay, it's scientifically or theoretically associated with increased ACE levels, but we never mention it. We never measure it. It's a non-specific finding, and they always confuse you with it, and a lot of you choose it while it's the wrong answer. Okay. So basically, these are the high-yield concepts that we have today. Let's go over and solve some questions together from our Synapse QBank to apply our knowledge to see if we're going to be able to solve them. Actual real questions. So this is our Synapse QBank. It's for step 2, it's 1,500 questions. So only targeting the high yield stuff. You do not have to solve like 4,000 plus questions. You have all systems here. So I chose I marked some questions for you guys from the endocrine section. You can also choose by discipline as well. And let's check the questions that I marked for you today about the topics that we discussed today. Let's discuss our 8 questions. And yeah. I hope guys this was useful for you. Okay, yes. Okay, thank you. Okay, let's start with this question. So how do I approach a question? First of all, I always read the question first. Which of the following lab patterns is most likely present in this patient? Why? This can give me at least an idea of what the question is asking, or at least what system the question is in. Why? This saves me time. This could turn out to be just a fixed question, or just a pure, for example, interpret this lab finding question, and I would waste a lot of time in reading such a big question. The second thing is I usually have a maximum of 5-second look at the answer choices, at least to give me a clue what system I'm in. So this, yeah, in the endocrine section, particularly they are asking, and this is the arrows questions that we were talking about, particularly they are asking about a calcium abnormality. Let's read the question slowly. A 64-year-old man with 20-year history of diabetes and hypertension comes to the office due to 4-month history of progressive dull aching pain in his lower back, pelvis, and hips with diffuse itching. Okay. So bone pain, what am I thinking now? So I'm always trying to flow down a funnel, okay, limiting diagnoses in my mind. Back pain and calcium problems, okay, maybe increased PTH. Let's move on. Hemodialysis, very important keyword, end-stage kidney disease patient. Okay, now I don't care about everything else. So I do not get like distracted by non-important stuff because I know what they're asking about. I don't get distracted by the insulin, for example, because yeah, mostly he has uncontrolled diabetes that caused his kidney disease. Pale conjunctiva, adjusted manifestation of anemia of kidney disease. Multiple excoriations, perioditis with kidney disease. I do not get distracted by these stuff. I do not even highlight them. Okay, so it's just hemodialysis. I'm jumping to look for my keywords: tenderness to palpation of the lumbar spine, nothing specific. Okay, his gait is slow and steady. Okay, just confirming end-stage kidney disease. All I want from here is end-stage kidney disease. Mostly I'm thinking, let's see what is going to happen. So in end-stage kidney disease, it's mostly going to cause an decreased hyperparathyroidism, right? That's secondary hyperparathyroidism. So it's not this one. So we do not have decreased parathyroid. Okay, we're going to have decreased vitamin D, makes sense. Decreased calcium, makes sense. Increased phosphorus, makes sense. Remember the flowing down the chart, starting by the primary event, increased phosphorus and decreased vitamin D, causing decreased calcium and increased PTH in response. Let's choose this answer and see. Yes, that's it. So that's the key. Just target the keywords and then look at it flowing down a chart. Here you have all the types that we discussed, okay? And why every answer is wrong and why is the other answers, why is our answer correct? How to approach them. And this is the table with all the arrows that I know a lot of you, I hope after this today, the arrows with the calcium are much clearer. Okay, let's approach this question. Following most appropriate next step in management. Okay, nothing much, but what I'm focusing on is they are telling me next step. Okay, so I know I'm choosing next step. I'm not jumping to a later step. Okay, let's look at the answer choices. It seems to be something, and it's an reference cortisol. It's endocrine adrenal. Okay, 46-year-old women. I usually highlight the age and gender. Some of these demographic findings can help. Okay, right-sided flank pain, non-contrast. Okay, there is a calculus. Okay, the CT scan incidentally revealed a 4.3 centimeter right adrenal mass. Okay. So this question is something that we haven't discussed in the previous slides, and it's something very important and very high yield. That's why I included this question today. So once you see an incidental diagnosis of an adrenal mass, the first step is for you to look if it is functional or not. Okay, functional, by functioning, we mean looking for hormones, looking for whatever hormones are getting released from the adrenal gland. Mostly here, I'm going to look for what? Measurement of plasma-free methanoephrine. This could be a pheochromocytoma, for example. Let's choose this answer and see why is it correct. So plasma-free methanoephrine, someone might tell me measurement of serum morning cortisol. Have you seen us mention serum morning cortisol in our in any of our like 3 investigations to confirm cortisol or Cushing syndrome? No. So that's why this answer is incorrect. Others do not make sense. They are jumping like a lot of steps ahead. Okay, so that's why this answer is correct, and you get the incorrect answers here. And all of the manifestations of adrenal masses, you have the pheochromocytoma, the Cushing, the primary hyperaldo, and so on. All of the questions, all of the diseases that we discussed. Let's jump to this question. Which of the following physiologic processes is most likely to be decreased in this patient and contributes to her current symptoms? Okay. It seems like, again, maybe hormonal, maybe renal. Okay, let's jump to the question. 52-year-old woman. Emergency department 2 days after undergoing total thyroidectomy. Okay. Intermittent muscle cramps. Since surgery, she had poor appetite earlier today, tingling in her fingertips. Again, this is a concept that I didn't include in the previous slides because I wanted you guys to get exposed to it freshly on this question. Okay, so I do not even need to continue the question. Okay, tingling in her fingertips, intermittent muscle cramps. I'm thinking hypocalcemia. Okay, let's look at the values. Yes, without even looking at the values, I know, because I know the classic manifestations and I know the keywords that they want to tell me. And after undergoing total thyroidectomy, that's my most common cause of what? hypoparathyroidism. So after a thyroid surgery, mostly because the parathyroid glands are located on the posterior aspects of the thyroid, so they can either get inadvertently removed or its vasculature can get injured, and so they are going to get we're going to get hypoparathyroidism. Hypoparathyroidism, that's the opposite. We're going to have decreased calcium and increased phosphate. So that's what we have here. We have the parathyroid hormone low, decreased calcium, and elevated phosphorus. Okay, so what am I choosing? If we have a decreased PTH, okay, that's what I have in mind right now. Let me go over one answer at a time and see if it makes sense. Conversion of 25 hydroxyvitamin D to 125 hydroxyvitamin D. Okay, this is a mechanism of action question. Does PTH actually cause this? We discussed that PTH, one of its functions on the kidney is what? To activate 1-alpha hydroxylase, causing activation of vitamin D. And that's can be one of the reasons to cause hypocalcemia, right? Let's try to check this answer, and it makes sense. So these are the mechanism of actions exactly on the kidney, on the bone, on the intestine, exactly like in detail. And this is the one that I focused on, the activation of 1-alpha hydroxylase, okay, and how you can reach the diagnosis and the how to know the physiological roles of PTH. And you can see the rest of the answers here. Let's discuss the next question for our time. Most appropriate next step in evaluation. Again, next step, I'm focusing next step. That's something very important. A 68-year-old woman comes for a routine annual wellness visit. She has a history of hypertension. Listen up. 40-pack year smoking history. Okay, once they tell me a lot of smoking history, non-productive cough, persistent. Okay, I'm already thinking this is a paraneoplastic syndrome, maybe, or they're saying about something like lung cancer. Let's go on. Chest radiography, they did the next step, which is chest x-ray. It was normal. Increased bronchovascular markings. That doesn't that. This mostly is COPD. This doesn't tell me anything about a tumor. There is no mass lesion. Okay, but I'm still not jumping to conclusion. This still could be a cancer, and it would only appear on x-ray. Okay, serum calcium is elevated, and then phosphate is decreased. So yeah, maybe there is increased PTH. I don't know. Okay, let's move on. Next step in evaluation. ACE level, I said this is always the wrong answer. Intact PTH. What do you guys think? Keeping it simple, even before going to the rest of the answer choices. Keeping it simple, hypercalcemia, I just told you. Whatever, even if you know the diagnosis from the clinical STEM, they want you to go step by step. So first of all, why not categorize it into PTH dependent or PTH independent? So here you have hypercalcemia. The next step is measure intact PTH. If you have it elevated or inappropriately normal, you're going to ask yourself, is CKD present? Because we said the most common two causes are tertiary hyperpara or primary hyperpara. Mostly in this question, if it turns out to be a malignancy, we're going to go down this road. PTH is suppressed, and then they tell you what's the next step. You tell them, okay, I want to do a CT chest. So always go step by step. Do not skip steps, please. Okay, let's discuss this question. Pelvic examination consistent with 14 weeks gestation. Most appropriate next step and evaluation. Okay. Okay, increasingly fatigued, emotionally labile, gain 10 kilograms. Okay, nothing specific so far. Arm rests to push herself up from a seated position, assuming her legs are just tired. So whenever they tell me inability to stand, inability to climb stairs, inability to comb my hair, they are talking about proximal muscle weakness. That's their way of saying proximal muscle weakness. That's a very high yield thing for any neurologic question or any weakness question. So we're already thinking proximal myopathy. Okay, vitals. Oh, we have hypertension. Physical examination, somewhat full face. Mild acne, scattered dark hairs, so we have some hirsutism. The abdomen is protuberant. Okay, we have these striae. I'm thinking mostly, what are you thinking? What I'm thinking, guys? I'm thinking Cushing syndrome. They are confusing me with the pregnancy. Maybe some people would think about pregnancy-related stuff, but keep it simple. Proximal myopathy, I have the full face, the moon face, the hirsutism, and the hyperandrogenism manifestations. The the abdomen is protuberant because of abnormal fat distribution. So we said, I want to confirm, first of all, is it Cushing or not? Maybe it's not Cushing. So out of these, the only one we said that is going to be one of the three answers that we're going to choose first is measurement of 24 urinary cortisol. So as we said, this is what one of these three, we're going to choose one of these three. And then the next step is ACTH, and then going down the flow diagram as we mentioned. Okay, let's discuss this question. We have which of the following next step in evaluation? Again, next step question. It looks like an adrenal question again. Okay. Hypertension. Lisinopril. Okay. So they are adding a lot of drugs. It seems like it's resistant hypertension. So I'm already thinking of a secondary cause. Okay, I'm now looking for the key word for the particular secondary cause. Significant muscle weakness, serum potassium 2.8. Okay, I'm already getting my answer. I told you guys the key word for the secondary cause that we mentioned is seeing abnormal lab levels. So that's like the upper limits of normal sodium, hypokalemia, and you're going to have what else? So the bicarb is elevated. We said there is going to be metabolic alkalosis. What's our diagnosis? Hyperaldosteronism. What did we say about hyperaldosteronism? People jump to CT scan of the abdomen. They won't just straight ahead to look for the tumor because that's probably the most common cause. But what did we say? Step by step. Yes, perfect. We are going to choose first plasma aldosterone ratio. First of all, is this hyperaldosteronism like associated with an increased ratio or low ratio? And then we can decide on which way can we move down. So again, endocrine is all about going in the right direction, next step. That's very important. So always keep it simple, guys. That's something I say, always keep it simple. Just look for the keywords. Do not get distracted by everything that is there. And that's the thing. If you know how to approach the question, what you're searching for, you'll just jump into the question searching for these things. You're not going to be intimidated by the length of the question or the weird terminology that they use. Okay, additional lab findings is most likely present in this patient. Again, it's a calcium question. Okay, so we have a 68-year-old woman, primary care physician, worsening diffuse bone pain, particularly in her hips and lower back, proximal muscle weakness. Okay, so this hints to a specific type in my mind of a cause of, we have bone pain and weakness. I'm mostly thinking vitamin D. Okay, increasing difficulty climbing stairs and getting up from a seated position. That's the proximal myopathy we discussed. Her medical history includes celiac disease. Okay, why did they want to mention celiac disease only out of all the medical histories that's possible? Why didn't they say if she's diabetic? Why didn't they say anything else? If they say one thing, mostly they want you to think about it. So celiac disease, we said celiac disease in addition to this bone pain and the muscle weakness, and you have the hypocalcemia and the decreased phosphate. Remember here we said vitamin D is going to be associated with both. Both are going to be decreased. Alkaline phosphatase is just going to be non-specifically elevated. And look, they actually did the definitive diagnosis for us. The vitamin D is already diagnosed. What is likely to be present? Would I have a decreased parathyroid hormone? Doesn't make sense. I have decreased calcium. The body should compensate by increasing PTH. Yes, yes. So I'm going to have elevated PTH, elevated parathyroid hormone. Okay, yes, makes sense. Again, going down over the algorithm, step by step, you get your answer. Looking for keywords, you get your answer. Okay. Again, what is the most appropriate next step? I'm focusing on next step. Okay, maybe some endocrine question. Let's look at the question itself. 33-year-old woman, worsening hypertension and lethargy 4 hours after an uncomplicated vaginal delivery. Okay, I know, guys, you guys got the answer because that's what we're discussing today. But let's go continue approaching it. Okay, there could be a lot of reasons. But then because I have this in mind, and when I saw it, okay, this gives me my diagnosis. But let's continue to make sure if there is anything else. She received 2 liters and still her blood pressure just had a transient improvement before dropping again. So this tells me that it's not the hypovolemia that happens here or not the bleeding that happens here that is the cause, because this should have improved with the fluids and it shouldn't drop again. Diffuse abdominal pain, we said that's one of the manifestations of decreased cortisol. Okay, somnolent, pale and cool, that's shock. Okay, I think we already have our diagnosis, so it's hypotension. Okay, moving on. Hyponatremia, okay, nothing specific. Hypoglycemia, okay, that's important. And so I know you guys know the answer. It's adrenal insufficiency, acute adrenal insufficiency. Like even without, like I just went over the rest of the question just to show you it's nothing I shouldn't be confused, they shouldn't distract me. So it's just, yeah, worsening. That's not improving. Literally the keywords which I gave you in the short answer. And hence why these short answers, and this is how our PDFs are structured. These short questions have the keywords that you're going to be looking for in such a big question. So yeah, it's acute adrenal insufficiency. We said what's the first step? Administration of IV hydrocortisone. That's deficient. We're just going to replace it. That's the answer. And here you have the difference again between primary and secondary adrenal insufficiency that we mentioned, but in a table format, and how you can differentiate between them. I hope this session was helpful for you guys. I'm sorry if I wasn't able to answer all your questions, but I was trying to make it as high yield as possible, trying to cover, yeah, thank you guys, trying to cover as much as possible of these, as much high yield things in a short time as possible. Again, if you'd like any personalized tutoring, you could just schedule your 30-minute free demo session and try the tutor for yourself. And as we mentioned, this is our Synapse QBank. Check out our free PDF files that we already shared with you guys. The links in the comments, you can find them. Our high-yield PDF files, they are for free, found on our website. I hope this was helpful for you guys. I wish you the best of your luck in all your upcoming exams. Thank you, and have a good rest of your day.